Good morning. Thank you for inviting me to present on lymphedema today. This session is shared with my colleague and fellow British Lymphology Society trustee, Dr Rhian Noble-Jones. I'm going to begin with general information on lymphedema, and Dr Noble-Jones will specifically address lymphedema affecting the genital area. Lymphedema is an incurable chronic inflammatory condition due to failure of part of the lymphatic drainage system, which supports its immune function. Radiotherapy can cause such damage, and if this affects the pelvic area, it will compromise its ability to collect and remove fluid and particles from the lower limbs and pelvic area, which would normally channel it via the lymph nodes to be filtered and returned to the cardiovascular circulation for elimination. Particles within lymph include bacteria, fat cells, and dead or dying cells. Swelling occurs due to stasis of fluid. It may start adjacent to the damaged area or more distally, depending on the drainage routes affected. However, it is the body's attempt to manage the stagnation of the particles within the fluid that, over time, cause an inflammatory response, laying down of fat cells, and a build-up of the cellular matrix that cause the characteristic changes, some of which are seen here in the thickening and increasing firmness of subcutaneous tissue with deepening skin folds and shape distortion. The skin also often becomes dry and more vulnerable. Initially, it may feel as if there is soft, watery swelling, which may pit on pressure, but it may feel more fatty or doughy, and if untreated, even quite hard and increasingly difficult to pit. It also increases the predisposition to severe episodes of infection called cellulitis in the subcutaneous tissues, and untreated, it can cause severe discomfort, increasing mobility and functional impairment, and consequential psychosocial problems. Now, we can't say for certain how likely it is to develop lymphedema after pelvic radiotherapy. Studies have reported anything from 3 or 4% to over 60%. And the variations in how studies define lymphedema, the selection of patients, and the length of follow-up make comparisons difficult. Studies are often small or retrospective case reviews, which are unhelpful, particularly because symptoms of swelling may not be recorded in the notes if considered mild or not troublesome. However, the good news is it's not inevitable, nor, if it develops, is progression to severe and more disabling lymphedema inevitable. But it is a lifelong risk, and the presence of other risk factors makes development and more severe forms of lymphedema more likely. So let's look at some of these risk factors. There are some risk factors related to the cancer itself, how the extent of it, the extent of surgery, how much radiotherapy someone has had, and also systemic treatments such as some chemotherapies or hormone therapy can cause retention of fluid. Post-treatment complications such as burns, damage to the skin, infection can be another risk factor. And also the type, location, and extent of the cancer. But there are some general risk factors related to the patient which are more modifiable and can help, if addressed, prevent the chance of developing lymphedema. Being overweight or gaining weight is a key risk factor. Being inactive, not using full muscle activity. If the compromise venous return, and other systemic conditions such as heart failure, which may cause chronic edema, need to be managed well and controlled. Infection, particularly if it's recurrent, And some medication, such as steroids and calcium channel blockers, are well known to cause damage to the lymphatic system and retention of fluid. So if lymphedema does develop, there are some things too that can prevent it progressing. So in general, for any patient, anything that can be done to target surgery and radiotherapy treatment and prevent complications after treatment is really helpful. Encouraging people to maintain a healthy weight and diet, to be active, and to look after their skin, making sure it's kept clean and well moisturized is really key. But if lymphedema develops, it's really important that it's recognized early and there's prompt referral to a specialist practitioner to make sure there's adequate compression treatment and lymphatic drainage, either by a practitioner or self-administered. And should cellulitis develop, that it's treated promptly and adequately. Detecting lymphedema early is really important. There may be observable swelling, but it is really important to listen to what the patient's saying about how they're feeling, because often that alerts you to some swelling, some changes going on before anything is visible. There are some self-report tools that help patients to consider whether they're having any of these problems and identify and draw it to the attention of the healthcare professional. But any complaints about clothing becoming tighter, digging in, any feelings of tightness, fullness, heaviness, or aching should really alert you that there's something going on. And at the very least, on clinic visits, patients should be asked about any of these feelings, anything they've noticed that might indicate that there is swelling developing. Now, right from treatment or before treatment and ongoing, it's important to make sure patients are aware of how they can help reduce the chance of developing lymphedema. So as part of prehabilitation, just bearing in mind lymphedema is a possible consequence. So daily washing with a non-acid soap, a neutral soap, and thorough drying and applying moisturiser will help keep the skin supple and protect the barrier function it has. Looking every day for any cuts, cracks, signs of infection such as athlete's foot is really important. But then protecting the skin from anything like sunburn, bites, stings, cuts from shaving, just being very careful, or maybe help from a podiatrist if they have difficulty cutting toenails. If something does happen, then cleaning the area with antiseptic and just keeping an eye on to make sure inflammation is not developing is really important. Keeping active is vital, and the British Lymphology Society have a campaign called Everybody Can, which is worth looking at. So for anyone, no matter how fit or unfit they feel, there is something that they can do to be more active, and there's lots of videos and help for them on there. Being careful about clothing, that it's not digging in, and particularly shoes that aren't going to cause blisters or any damage to the feet are really important. Patients should know what to look for in early swelling, early signs of lymphedema. And they should also know how to recognise early signs of cellulitis, which is a severe and really a threat to ongoing lymphatic function if cellulitis is not treated adequately. So they should know how to recognise it and the importance of reporting it early. It doesn't always behave in the same way as cellulitis in someone who doesn't have lymphedema. It may be the cause of lymphedema if it happens, or it may be because of lymphedema. It's usually quite a sudden onset. It's always unilateral. If it happens in both legs, it's probably not lymphedema. But the first sign is often a fever, feeling flu-like before any other symptoms appear. There may be redness, there may be a rash, but there is usually swelling or an increase in swelling, and there is usually pain and discomfort. There is a consensus document guidelines for cellulitis in people with lymphedema on the British Lymphology Society website. It's just been revised and will be available from October, but it is really important because it advises slightly different regimes from normal cellulitis, and it's really important to stop it being a recurrent problem. So in summary, the lymphatic system is resilient. It's even if compromised by pelvic radiotherapy, but there are strategies available to reduce the burden of any lymphedema that occurs and to reduce the chance of getting it in the first place. But early recognition, reinforcement of those preventative strategies is critical. Referral to a lymphedema practitioner is also really important to make sure that appropriate compression is applied, because it should extend beyond the extent of the edema, which often means it's from toes to waist. But they can also teach the patients how to do self-lymphatic drainage to minimize the risk of progression and maintain that quality of life. The cellulitis guidelines are available on the British Lymphology Society website. It's on the front page, and as I say, will be changing, so look out for it after October 22. Thank you very much for listening to this presentation. I'll now hand you over to my colleague, Dr. Rhian Noble-Jones, who will continue to talk about genital lymphedema. Thank you.
Thank you, Margaret. I'm going to extend a little now on what Margaret was saying about lymphedema and specifically speak about genital edema in relation to pelvic radiation disease. My name's Dr. Rhian Noble-Jones, and I'm also from the British Lymphology Society. I'm the chair of the scientific committee there, but I'm also lymphedema researcher for Lymphoedema Wales and a senior honorary lecturer at University of Glasgow. Now, genital edema, just to be clear, is an umbrella term that covers the long-term chronic edema in the genitals, genital lymphedema, but also you'll see in literature hydrocele being referred, which is a particular swelling within the lining of the testes, which obviously only happens in men. But the umbrella term genital edema refers to men, women, and children. And today we're going to be particularly thinking about that in relation to radiotherapy, of course. The reference there is for a particular supplement that has a lot more detail on this that you could refer to should you wish to. Now, how common is genital edema? Well, thankfully, it's fairly rare. The lymphatics in the pelvic area are very good at finding alternate routes to deal with swelling. But you'll see now, as I just go through a little bit of the anatomy, why radiotherapy in that area can affect the lymphatics. But in general terms, we're thinking about at least 1 in 10 people who, if they have swelling in their legs, particularly in the thigh area, will probably have genital edema, and it's worth those people being assessed, either with some direct questions as to function of that area or by examination, of course. One of the things that we do know for sure is that obesity is a significant contributory factor. So those are the patients perhaps that you would think even more so to check that area for them. Now, I'll just quickly look at these. The problem with anatomy drawings that are used in undergraduate training is that either the lymphatics aren't shown at all, or that they're shown a bit like this in the male, this in the female, where they're very big and clear lymph nodes. Of course, in real life, they're not as clear as this at all. They're all different sizes and they're covered in adipose tissue, so very difficult to find. And so to avoid them in terms of surgery or radiotherapy is almost impossible. You've got to deal with the cancer that you're treating. So we deal with what we find. And to save the blushes, I've used pumpkins as examples here of the shape and size distortion that can happen. And as Margaret referred to earlier, it starts off very benign looking, really. It's very soft, it goes up and down. It can change as the day goes on or as the weeks go on to begin with. But ultimately, if it's not dealt with, it becomes hard and fibrotic. And that's why we want to see these patients sooner rather than later. So what we would use in the lymphedema world is perhaps first a self-report tool for patients. This is the female version that I was involved in designing, but there's a male version as well from the British Lymphology website. And it's a way of the patients opening up that conversation with the patients about what problems they're having, and perhaps a bit less intimidating than asking to look straight away at the problem. Now, if they reach a lymphedema service, you'll find that there is a whole host of treatments that can be given within the clinic by the lymphedema specialist, but they ultimately go towards the patient finding skills that they can learn themselves to manage the condition themselves. And that's their ultimate aim, that it's self-management for the patient. So finally, the professionals, you can approach British Lymphology Society, of course, and patients can go directly to the Lymphedema Support Network. If there are any questions in particular about this presentation, then please do feel free to email me directly. Thank you, and congratulations on the new document.